welcome everybody to this evening. So I've got three speakers this evening. I'd like to welcome, we've got Dr. Sid Chawla, who is the Clinical Director of South Hardwicke PCN. We've got Duncan Gooch from the Derbyshire GP Alliance, and we've got Steve Lloyd, who is a South Hardwicke GP and also the chair of the CCG.
Correction, I'm Executive Medical Director of the CCG.
Executive Medical Director.
Esteemed colleague, Dr. Abby Bhatia is the chair of the organisation.
So apologies. So I'm going to hand over in the first instance to Sid. The plan for this evening is that each of our speakers is going to talk for approximately 15-20 minutes, and then there will be an opportunity for questions, probably questions at the end of all three, because it may be that if you've got a bit of a question, it might actually be relevant or linked to somebody else's talk, so that opportunity to ask later. And if we can put the questions, if you've got questions as you go along, if you want to put them in the chat, I will be looking at the chat as we go along, and then we'll sort of chair the question asking part of the session at the end. So I'm going to hand over to Sid Chawla.
Sorry, yeah, I'm still on mute. Right, unmuted. Right, so I have a presentation on PCNs as Tara has introduced. Now, I didn't realise there'd be like 20 odd people on there. I thought mine be 4 or 5. So I hope you find this interesting. I'm just going to try and get it all set up now. And let me know if you can now see my screen. Yes, thank you. Right, so as Tara introduced me, I'm Sid. I'm a GP in Wingworth, been here now for over 15 years. I put myself forward about 1.5 years or so ago to be the PCN Clinical Director to South Hardwicke. I have a few aims for tonight on here. So my aims were, what are PCNs, how were they formed and what do they do, who are they accountable to, if anybody, and what makes them up, who's part of the PCN. And then, given that I thought a lot of people here would be from South Hardwicke, I thought it would be useful for you all to know what South Hardwicke PCN has done for you and your practice. At the end of the day, PCNs are your practices. Are there any other aims or any other ideas or thoughts that anyone may have from today? Have I missed anything off? If I have, then just put your hand up or let me know, and I'll ask Tara to direct, because I actually can't see anything else apart from my screen now. So first things first, what are our primary care networks? So in summary, there are a bunch of practices coming together to work at scale. It's been a priority of the NHS long-term plan to try and do this, and therefore primary care networks are seen as the building block or key building block to do that. So the GP practices are all coming together to work at scale, to recruit and retain staff, to be able to manage the financial and estate pressures that we're currently facing within the NHS by working together. And therefore, by doing that, we're providing a wider range of services to patients, recruiting and retaining different types of staff members. And also, one voice being able to work our way up to the CCG. So we have easier integration with the wider system. That will be with our community partners, such as DCHS and the CCG. How were they formed? The basic population of a PCN, originally they said, shouldn't be much bigger than about 60,000 patients. South Hardwicke is a little bit bigger than that. It is 61,000, it's coming up later. and some areas such as the Dales, given their rurality, is actually up to 80,000, but that's simply because of how they are structured. It's all geographically based, so we can all develop our networks for patients covering the practices within one CCG boundary. So we've got Derby and Derbyshire CCG at the moment, and South Hardwick, you'll see a map in a little while where that sits within Derby and Derbyshire. So obviously we're surrounded by other PCNs within our CCG, but there are PCNs who are boundaried with other CCGs, which adds a little bit of complication to their strategic direction. It's not mandatory to be within a PCN, so the practices that have decided we're going to work as part of a PCN have decided to opt in to do so. Opting out does mean that there is some significant funding loss for those practices. And then also those patients may not receive the services that the other practices joining them may. But there is a ruling, from what I can read in the guidance, that says that if a patient's practice is not within a PCN, it's imperative they are offered a similar service to those who are within the practice of the PCN. So what do we actually do, really, apart from have meetings every week and try and manage COVID? It's basically, before the whole coronavirus pandemic, the PCNs were trying to be a delivery vehicle for the long-term plan. Things like the medication reviews, the enhanced care and care homes, anticipatory care, personalised care. The list is quite clear to see. However, the COVID pandemic has brought a change to that, and we were seen as a vehicle to help practices overcome and manage the pandemic as best we could, with regular review, with regular meetings with the CCG and the wider community. So being a vehicle to deliver services was originally where we were, and we're still asked to do that with the pandemic dying down a little bit. So by offering those services, we were expected to try and either employ or second certain staff, and we call them additional roles, or ARRS, which stands for Additional Roles Reimbursement Scheme. So these specific roles are reimbursable, so they're paid via the PCN, and then the PCN is reimbursed the cost of their employment. So a social prescriber, I'll explain later what South Hardwick have at the moment. Clinical pharmacists. They also PCNs are also expected from April to offer the extended access hours. We can also offer PAs, which are physician assistants, and paramedics, but there are a large set of roles that we can employ, which we'll go through later. Because the PCN is a certain footprint, and again I'll show you the map in a little while, there's an expectant that the community services and the mental health teams will mould themselves around that footprint, rather than us mould through to their footprint. And we actively meet with DCHS and hopefully soon the mental health team to help with that integration, and I hope that we form a wider community service. So we focus on delivery and with the building blocks to an integrated care system within our PCN. But what I thought was really useful is that it's where primary care representation is made stronger within those. So rather than being asked to do things by the CCG, etc., we turn it around and we say to the CCG, this is what we'd like to do and how we'd like to do it, and we get on with it. And hopefully the community services integrate around us and with us, rather than dictating to us how they'd like to offer things. So you might think, well, how do we do all this? Where does the money come from? Well, a PCN is is a group of practices, like I said, coming together. There are different ways we could structure it. So you could have a lead practice that takes on all the managerial aspects of the PCN and also holds the purse. And you can see the PCN will be given £1.50 per patient weighted population. So we get the equivalent of about 70,000 patient population. So you can imagine the actual purse that we're sitting with at the moment. And actually each practice gets a significant amount of money as well, £1.76. And that is aimed to allow the practice to free up time to offer clinicians and staff to help the PCN work. Other ways of funding is, as I said, through the additional roles reimbursement scheme, where there's a 100% reimbursement for the employment of roles such as social prescriber link workers and the community pharmacists, clinical pharmacists, apologies. And then come out just now, very recently, wasn't here last year, is the Investment and Impact Fund, which is a similar to a QOF that we have in general practice, and it's a payment based on results. I'm not going to go into massive details about that. It is about 50 pence or something around 50 pence per patient if we hit certain targets, but that was being put on hold a bit through COVID, but should be coming back to us in October, so we'll see. So with all that money that's available to us, we're trying to develop this integrated system with our community teams to improve the care within our areas. And these are the roles that we have the ability to employ. You can see there the social prescriber link work I've mentioned a few times, and clinical pharmacists. They were the first set of roles that we could employ, and this year now we've got physician associates, FCPs, wellbeing workers, dietitians. So you can see what NHS England are looking at trying to achieve through this. And I apologise, my spelling at the bottom of the one there. It's basically these are additional roles. So these aren't roles that we are giving. Let's say we go through DCHS, say we want to develop something. This isn't to subsidise what they currently do. This is actually, well, we want more, and here's the money to do so. So we want more dietitians. Again, apologies for my spelling. So rather than saying, well, we don't have enough and we'd subsidise their hours, we can't do that. It's more a case of additional roles, and that's where the money follows for additional roles. I've been talking. Does anyone have any questions, or shall I carry on? Nothing's come up. So who are we actually accountable to? Well, the practices, the partners of each practice sign the network agreement, which says that we're happy to work together and form a PCN. Are we accountable to the CCG? Some people would say yes, some people would say no. I don't think we're accountable to the CCG. I would say that the CCG does keep an eye on what we do and what we spend our money on. And we do meet with the CCG regularly to get ideas of what areas that is being worked on locally rather than just within a network, so we're not duplicating work. But each network has an accountable CD, and in South Hardwick, I'm the accountable CD, and I'm supposed to be the one that provides the voice from the practices up into the wider integrated community, ICS and the CCG. I'm supposed to also be the contact for the ICS and the CCG to bring information down, and that worked really well, I felt, through the coronavirus pandemic, where information from the CCG, public health and infection control came through me into this PCN on a weekly meeting. But the main thing is we're not really accountable for the performance on what we do, or the member practices. So our performance is not looked at or frowned upon if we don't achieve targets or what have you. We're there to try and improve services. So this is a map of Derby and Derbyshire primary care networks, and we are, it's the pink one here. Can you? I think you can see my mouse moving around there. So you can see how the large span of Derbyshire Dales, but that is purely rurality. And you can see that their size is 81. The largest by far is Chesterfield, who actually work very close with Dronfield due to their proximity, and that's working well for them. South Hardwick, you can see, does boundary there with another CCG. I believe that's the Alfreton area. It's working really well at this moment in time. I believe that the PCN's gone from strength to strength and has actually employed a few additional roles, and I'm not sure if you guys are aware of those, so I was going to summarise the South Hardwick PCN at the moment. So these are the practices that make up South Hardwick. There's us at Wingworth, Claycross Medical Centre, and there's Moodykes and Grassmore, which is currently RPC, North Wingfield, and the two in North Wingfield, the Medical Centre and St Lawrence Road, Stafford Health, and then Lambs Village and Blackwell. So in total we make about 67,000 patients. So with the 67 follows that funding that we were discussing before. So with that purse, what have we achieved so far? Well, we originally employed 3 social prescribers. We've now lost one due to illness, so that's gone to 2 social prescribers. And what have they achieved so far? Well, we originally set out with a plan to improve the diabetes, the health of diabetics in South Hardwick. We were outliers in the 3 Ts for diabetes. We found that our diabetics were at higher risk of amputations, heart disease, etc., due to that, and therefore we had a plan where we do a study on referrals into social prescriber link workers, or the diabetics who had either high cholesterols or poorly controlled HbA1cs, or the other 3 Ts treatments. I can't remember now off by heart, but high blood pressure, poorly controlled diabetes, and high cholesterol. They're the 3. So anybody who's poorly controlled with their diabetes in South Hardwick can be referred to the social prescriber link worker. Type 2s mostly. I don't think they deal much with type 1s. I think type 1s are hospital-based mostly. So the type 2s, you can refer into the social prescriber link worker. If you don't know how to, speak to your lead in your practice, either your diabetes lead or your PCN representative, and they'll be able to tell you how. It's very easy on System 1 to get that referral in. Weight management, we've got one of the social prescribers really hot on getting people to lose weight, and then that has a roll-on effect with the diabetes. They help with for some patients filling in forms, so Citizen Advice Bureau forms or Live Life Better. Some people found that they weren't going to their weight loss management simply because they couldn't fill in the form, or they couldn't go online and do it. So it's done for them by the social prescriber. So they've been doing a lot, but mostly over the last few months, and I apologise again for my spelling, calling those shielding COVID patients who were really isolated and vulnerable, and making sure that they're getting food, getting medication, and just making sure that they were kept safe, and those secluded at home. They also work quite closely with care coordinators within the surgeries that we currently enjoy in South Hardwick at the moment. And then we have been very fortunate to employ Jess, our clinical pharmacist. So she works within South Hardwick. She's currently training up to get her necessary qualifications, but is able to do things like medication reviews. She's been producing policies for high-risk meds to make sure that all practices have got policies in place for patients who are on DOACs, for example, making sure their monitoring's up to date, and methotrexate, etc. Just making sure that the care is standardised throughout the whole of the PCN. And she's been keeping on top of changes with COVID medication. I'm sure she's been putting out those bulletins that she's been showing us on medication availability and things like that. So she's been doing a sterling job, really helping practices. Other achievements, well, you might remember even pre-COVID, we had a large meeting where all practices represented, looking at the digital platform. Well, the PCN took that on for practices and arranged for the different providers to come and present, and we all opted for eConsult, which I think every single practice is now using within South Hardwicke for triaging patients during the pandemic, which we're quite proud of. We've also started offering this enhanced health in care homes. Now, this was an NHS England ask really, where we have to develop and run a service to those vulnerable adults in any CQC registered care home. So we've run with that. We've got a lead, Dr. Ruth Cooper, who has really taken on and produced a really highly functioning MDT. We've got DCHS represented in there with a care coordinator. They have an MDT every week, and we're ticking the box for enhanced service, and we're waiting for some feedback. Yeah, it's been going on for a couple of months now, so we'll hopefully get some feedback back from the care homes to see how that's worked. But we've done exceptionally well with that. Quite proud of that work. And again, pre-COVID, we did review of opioid prescribing. We had a large quest where I believe our colleagues in the north joined us, where we were found, South Hardwicke found to be the third highest prescribing PCN of opioids and gabapentinoids, which shocked us completely to the core. So we held a large quest where we had health psychology in and the medicines management team in to try and help reduce our opioid prescribing, and we all made a pledge to try and do it. We all made plans to do it, and then a month later coronavirus took over the world, and unfortunately the South Hardwicke weren't able to take it much forward, and I haven't really asked practices to give me numbers yet, simply because there's too much going on, but it's something we'll pick up again, because it's something we really we're quite proud of when we did the quest, that we're really working together to try and reduce that. Oh, there's more achievements. These educational sessions, and thanks go out to Dr. Todd, Dr. George and Dr. Miller for organising these. I mean, these are great monthly sessions where we can all enjoy our meeting together and improving our education and getting our CPD time for appraisals. And then the enhanced services. I mean, there are enhanced services that the PCN should be delivering on. There are some that we have done, such as the care home and now learning disabilities. But with COVID, we've had to just take a step back and just focus our thoughts on COVID and make sure everyone's supported through it. And this is where I was coming from. I think as a PCN, we really worked well together, giving support, giving advice. We changed from monthly meetings to weekly meetings with lead clinicians, just making sure, and practice managers, just to make sure that everyone was doing fine, offering support and advice, and making sure that everyone was putting in if anyone had spent a lot of money on doing things for COVID, that they ensured that their funding was right. And then the red clinics, we were asked to try and get some red clinics together, and you know what, practices ran with it straight away. Staff have got their own red clinics sorted. Landville, Blackwell did theirs, and the 4 smaller practices up in the north of the PCN individually worked fine, but they had an agreement where we could work together if it was necessary. But thankfully, numbers didn't get that high. Future, what I want to do in the future, definitely website for the PCN. We've got an exciting future with the FCP physiotherapists. We're in a company, in talks with a company who will offer physiotherapy triage within 48 hours of presentation or referral. That looks really exciting, and then they can feed into our current physiotherapists at DCHS and MSK. So they can offer MRI scans and refer for those and what have you, and blood. So that is something that it's taking my priority. We're looking to expand clinical pharmacist and employing a pharmacy technician. That's proving harder due to numbers. However, like I said, we've got Jess at the moment, and we're quite pleased with the progress she's making. And then I think Joined Up Care Derbyshire and a larger footprint, they're looking at delivering of a community visiting team with DCHS. So that again is quite exciting. South Hardwicke have already expressed their interest in that. So that's the end of mine. you've all been very quiet and patient, but do you have any questions?
Oh, I've got a question. So, Saurabh, you've got a question. Do you want to ask?
Need to unmute myself. Thanks very much. It sounds like everything's going really well, and PCNs are a wonderful way forwards, although COVID's tried its best to mess that up. Great presentation. Can you hear me okay?
Yeah.
Yeah, and I just wanted to say the mental health side of things is coming in soon. I mean, I think April, isn't it, that next year that you might be having the funding ready for some new roles. I would be interested to know, from your point of view, how you envisage that working, and sort of what you think you would want to see. It's obviously not going to be simple because we've got masses of mental health workers out there already, but trying to get, you can employ somebody yourself for the practice, I think, isn't that right? Or for the PCN.
Yeah.
How would you like to see that develop? Because I might be able to help a little bit with that.
Yeah, I've been on calls with yourself, Saurabh, and it sounds really exciting. Some of the ideas that come out. I think the South Hardwick have not really moved on forward into the thoughts of the community mental health side at the moment, simply because of structural issues and different things we need to sort out before we get that as an employing body. However, there is at every meeting when we do discuss ARs, it's always brought up that we need some form of help with the low-lying mental health patients where they're finding it difficult to get hold or into IAPT, for example, and they're really on that boundary between IAPT and the community health team. And I think CPNs or community psychiatric nurses were quite sought after beings. I think we would like to work in close association with what's there at the moment, in a hope that we don't destabilise what's there and rob Peter to say Paul, if that makes sense, and
Sure.
really work with the service providers to see what additional roles can be funded through PCNs working integrated with them.
There's going to be a big push to integrate, primary care, but also secondary care and also the voluntary sector roles, so that instead of thinking of it in the traditional, doctor, CPN type way, it's probably better to think about things in a new way, which is just meeting those unmet needs, which may not require a degree in psychiatry. You know what I mean? So it'd be great to have more discussions about this. Thanks.
No, thank you, sir. That was really useful. Thank you.
Yeah.
Brilliant. Have we got any other questions? Nothing's come through on the chat. Otherwise, I think we will thank you very, very much, Sid. If you do come up with any questions that you want to ask about things at a PCN level towards the end, I'm sure Sid will answer them later on. So I'm now going to hand over to Duncan Gooch.
Hi, thanks a lot, Tara. Good evening, everyone. I think it's terrific you've got 23 people on at 8:30 on a Tuesday night. That's fantastic. I thought Sid's presentation was great, and he really effectively, I think, described what PCNs are there for, which is around that integration of care and then the sort of the operational service delivery. So very much about the frontline delivery of care to patients, which was, I thought, a useful way of sort of framing it, Sid. I'm going to share a quick presentation, and the purpose of this presentation is really focusing on the three-letter acronym thing, but looking at a scale between a PCN and up to the Derbyshire system, so up to this ICS system. So Sid's sort of done the PCN level and down, so I'm then sort of doing up to the next level with it. And just to make sure everyone's awake, and this is a test, because if you're not awake, then I will see that you've not commented. I wonder if you could write in the chat as many different 3 or 4 letter abbreviations that you're aware of in the sort of Derbyshire area. And as you do that, I just introduce myself very, very quickly. So I'm a GP. I live and work in Long Eaton, which is in the south part of Erewash. And when we sort of had the Vanguard, I was the clinical lead of that, and then have gone into being a clinical director for the Erewash PCN. So the equivalent of SID down in Erewash. And in addition to that, I've sort of helped form with others a GP alliance, so trying to get a Derby and Derbyshire wide voice for general practice. So that's my background. In addition to that, I'm a trainer. I'm just one of these very restless GPs that likes to do lots of stuff. So trainer, medical students. I've been a partner down there for about 10 years. So how many have we got? Oh, nice. Lots and lots of different ones. I've missed half of these as well. So I did a little crib sheet just so I wouldn't forget. So I'll pop the slide up now. And I know at least 4 people are awake, so I'm feeling confident. So the list that I came up with, I've put on here. I'm not going to read through them all, but it's absolutely awash with these abbreviations. And so I thought the best way for me to go through this presentation, just for the next 5-10 minutes really, is to try and explain things from my perspective. I'm a very simple person in that I like clear logic and clear reasoning. And so I will try my best to walk you through what I see as the sort of the Derby and Derbyshire system. So what it is that we're working in at a level above that of a practice and of a PCN. And so the first thing that I consider is the idea that we have payers in a system. So a payer is someone that's purchasing services from you. It's where your money comes from. And in Derby and Derbyshire, we've got 3 main payers for health and care. We've got the CCG as a payer, and we've got the county council and the city council. And they're the people that are mostly purchasing health and care on behalf of all of the residents of Derbyshire. And those and they're purchasing it, and it's really important to then understand the context in which they operate. So they operate in a highly politicized way. So if we consider the council, city and county, they are directed by elected representatives, so entirely politically driven, and they have some fantastic people working sort of within that as permanent members of staff, but are influenced and have to sort of appease the political wills. And I think that's really important. And within the CCG, whilst it's not directly politically influenced, it's very heavily indirectly politically influenced. And the most recent example that just screams in my mind is what they expected of us with care homes through, I think it was early June time, through COVID, where there was clearly a load of media attention around the increasing deaths in care homes. And so what happened was NHS England had to do something to respond to save political face, and what it did was then insisted that every care home have a nominated clinical lead, and that we do that within about 3 days and turn around a load of reports, which Sid will have been doing behind the scenes. So a really easy example where these payers within Derby, Derbyshire are really politically influenced, and that's a real challenge for them because there's not a lot they can do about that. The other bit that's really important about these payers is they have a number of statutory obligations. So there's some stuff that they just have to do. And it's very easy for us to sort of blame other people for things not being done. But actually, ultimately, and particularly the CCG, there's a whole series of statutory obligations for which it doesn't have a choice. The decision is not with the CCG for a lot of the things that are related to the payment and purchasing of services. So within Derby, Derbyshire, we have a set of payers, and then we have a set of providers as well. So this would be, as Sid's described, PCNs, but it would also be the practices. It would be DCHS, DHU, UHDB, Chesterfield Royal, Royal Primary Care, EMAS. So we've got a whole collection of these providers that are working throughout the whole of Derbyshire, delivering health and care to all of our residents. And when we bring all of those together, so when we bring the payers and the providers into a single space, this is what we call the system. And it sounds like a ludicrous thing, and it's a really, we've got all of these cogs working separately, and it's just to try and bring them into one place. And we often hear the system being referred to, and I do it quite a lot accidentally, but when we describe the system, this is what we mean. It's the system of health and social care, and that's the payment of health and social care and the delivery of health and social care, and then to some extent the regulation as well. And so that is what an ICS is. So an integrated care system is the integration of all of those functions and services within one. And the STP that I can see sort of Lindsay's referred to in the three-letter abbreviations was a few years ago. That's what it was called. It was a system transformation plan. That was renamed as Joined Up Care Derbyshire, or JUCD, which is another one of these abbreviations that we hear of. But fundamentally, it's a bringing together of the health and social care facets of Derby and Derbyshire. So one of the things I always ask myself is, well, what's the point? Why do we need to do it? What are we actually trying to achieve? Because when I see my patients, I do a pretty decent job of, well, I like to think I do a decent job of sorting out the problems that they're there with and delivering that care. And by and large, they quite like me, I think, and tell me I do an all right job. What's really important is that we see the bigger picture with this. And what is the point of a system coming together? And fundamentally, it's trying to do four things. So this quadruple aim, which is stuck on the top of every one of these system meetings that we have. And so one is to improve the overall experience of care that a patient will have. So make sure that experience a patient had is as good as it can possibly be. Secondly, it's to try and improve the overall health of a patient as well. So that's health and well-being. And so often at a high level, we're talking about life expectancy and healthy life expectancy. So we want to reduce the amount of time that an individual is with disability. So their highest possible healthy life expectancy and an increase in overall life expectancy as well as a top level aim for the health and well-being, although there's lots of nuance and detail that sit underneath that. Thirdly, there's an aim to try and reduce cost. We're in a financially constrained system in Derbyshire, or Derby and Derbyshire is particularly financially constrained, which has a lot of undesirable consequences, I think. And then finally, so this was a triple aim. The quadruple aim came in a couple of years ago, where actually the well-being of staff is important. So actually focusing on making sure that we look after the team that's delivering care. We focus on the staff experience, the staff well-being, because we know if we do that, patients will have a better experience, we deliver better care, and it won't cost as much to the system. So if that's what we're trying to do, so look at a very high level, improve life expectancy and improve healthy life expectancy, and we're trying to then look at patient experience and reduce costs and look at the sort of the well-being of staff, we then consider, well, what are the determinants of that health? So if as a system we're trying to achieve an improvement in life expectancy, an improvement in health, we need to consider then how we might do that. And when we look at the determinants of health, this is a fairly broadly quoted study, and there's several similar studies. To be fair, a lot of them are US, but there are some correlations with the UK data, which show that actually the direct delivery of care only equates to about 20% of a total health outcome for an individual. There are far greater determinants of health, particularly around the social and economic factors, and this splits it down. And so this slide is an entirely cut and paste slide from Dean Wallace, who's the Director of Public Health for Derbyshire County Council. And his argument, which I think is a really valid argument, that a lot of the health behaviours that we see, which are really important determinants of overall health outcome, are probably secondary to socio-economic factors. So we know things like income and employment, community safety, education will have an impact on the diet and exercises choices that people make, the smoking choices that people make. And so when you look at health outcomes and you look at us as an individual GP who's really just trying to improve the health outcome, it's really clear that we can't do this alone, and we must do this in the context of a system that's looking at all of these different things and trying to work together. So what does it mean? I think so I've spoken a load of rubbish, and a lot of the stuff that I think about is a bit theoretical, really. It's a bit sort of stating the obvious. So what does it mean for us, and what might we then infer as implications for us as GPs? So it's clear that we need to focus on the outcomes rather than the output. So we need to look at, are we increasing life expectancy rather than the number of people going to A&E? And are we supporting people better in their care homes because they are living a longer period of time there, or we're reducing admissions into care homes rather than non-elective admissions? And this is one of my personal bugbears, but rather than looking at all of the outputs, which we are so frequently counting, we are seeing and will continue to see a shift towards focusing on outcomes. Now, general practice has more or less had a capitated budget for quite a while. It's something that we're quite used to. What happened through COVID is the same happened to hospitals. So they were given effectively a block contract. Say, this is your amount of money, now live within your means. And this has been a strategic direction of travel for the NHS for at least 5 or 6 years, but probably slightly longer. So when Andrew Lansley introduced the idea of competition to be the saviour of the NHS, quickly it was recognised that that wasn't the saviour of the NHS. And so the focus into sort of capitated budgets for a whole population for the delivery of their health and care needs became the new thing we're working to. But we've been working towards this in the context of the Lansley changes to legislation, and so there's an inherent challenge. And what's very interesting, and if you look at global health and how that's moving, this strategic direction came out of the Obamacare Act, where he started to describe these accountable care organisations. So these organisations that were accountable for the health outcomes of a population for a fixed budget. And it's really interesting to see how that's changed over time. But actually, what we were talking about 4 or 5 years ago, plus actually, around capitated budgets really hasn't changed. It's fundamentally still the same thing. And this is really important for general practice, because there's going to be a clear movement of work into a place where it's most appropriate from the patient rather than the place where it generates the most income. And that fundamentally is really important. And then finally, what's clear as we work as a system is that there'll be an increased focus on health inequalities as well. So what about general practice? So where does general practice fit in this real big system of health and social care? Because sometimes it can feel a bit left out, I think. And for me, it's just the most integral part of the whole system. I would say that because I'm incredibly biased, but that's me. It delivers about 90% of the activity, we know that, but what that means in Derbyshire is nearly 500,000 appointments a month, and that is just a huge number of appointments. It's difficult to sort of realise how many that is, and we know at the moment that we're delivering at least sort of 30-40% face-to-face. So in spite of what the NHS and the Telegraph might be telling us, we know that a lot of those contacts in general practice are occurring face-to-face, and we offer an incredibly dynamic and flexible response to meet patient need. And I don't think our response to COVID in that first week or two was phenomenal. We utterly turned our worlds upside down and carried on delivering really safe and effective care. But in this world of a system and health and care, we need to be seen and we need to be heard. And it's really frustrating to not have a voice of general practice historically sat around the table. And what we've done and the work of the PCN clinical directors, GP Alliance, has started to go some way to do that. And we're not there yet. I'm sure Sid will have shared the general practice provider board proposal, in which we try and further legitimise and strengthen the voice of general practice as a system. But it's so important that we have some form of collective response and leadership at a system-wide level for general practice. And then finally, and the what about general practice is, if we see what's happening around us in the system and I suppose the country as a whole, we can see that hospitals are struggling with their demand on their routine appointments, and they're particularly then struggling to deliver some of that face-to-face care and investigations. And so if we were planning for our future, so as a practice or as a PCN, and you were to look 2 to 5 years into the future, you would say that actually I need to be considering how I might be able to deliver, or with my local community partners, easy access to ECGs and diagnostics and phlebotomy. And there's a whole series of this longer term planning that we can start to do when we look at what's happening within that health and care system and the direction of travel that it's going in. So I'm going to stop there, mindful of time and mindful that Steve's going to come in and talk about sort of the level of sort of the ICS up to NHS England. Tara, I don't know if you want to do questions now or wait for Steve to do his and then bring them all together.
I think there is one question from Stuart, which I think is a pertinent question to be asking at the current moment, and then if there are some more questions, maybe we'll do those after Steve. So Stuart, if you wanted to unmute yourself and ask the question you put in the chat.
Hello. Yeah, you made the staff well-being came last, which is somewhat why?
Yeah, so I described it last because the infographic I found on Google Images had it as number 4, so that's the reason that I put it last. Interestingly, it wasn't even last until about 2 years ago. It just wasn't in there at all. So if we were looking at, so this came from the Institute of Healthcare Improvement, which is a Don Berwick headed up in the US, and this has come out now globally as the sort of thing to do. And lots of people have heard of the triple aim, and then it became increasingly apparent. I think it was 2008 he published that, and that was sort of doing the rounds, and now is embedded in almost every health document you will see, I think, in the world. It's certainly every one that I've ever looked at. And it was only over the last few years that there was an increasing recognition of the importance of staff. Staff were almost the tool by which you would deliver that triple aim. And so that's why it's then come in last. And I'd absolutely agree with you, Stuart. It's ludicrous that it's not the top priority. I couldn't agree more. And actually what's been really interesting is the people that have advocated most for the inclusion of staff within this, within Derbyshire but wider, have been clinicians. It hasn't been the broader staff, because sort of the broader sort of senior managerial staff, although they absolutely agree with it and completely endorse it, the most common people that I hear talking about the importance of staff wellbeing are the people closest to the delivery of care, to patients, or whatever the current word for people receiving care is.
If it comes in after cost savings, then there's no point in it being there at all.
Well, it's about value for money, isn't it? But I don't think we disagree.
Well, slaves were good value for money.
Okay. Right. At this point, I'm going to hand over to Steve to take us up to CCG level. And
yeah, thank you, Tara, and evening, colleagues. Some of you I know, some of you I don't. I'd just like to say I'm Dr. Steve Lloyd. I'm the Executive Medical Director of Derby and Derbyshire CCG. Many colleagues on the call will probably recognise me as previously chair of the old Hardwick CCG. Just picking up the thread from what Duncan was saying about the position of general practice within the system. When I assumed the role of Executive Medical Director, one of my strong ambitions was to see a united voice for general practice in Derbyshire, and a powerful voice, and that powerful voice reflects the activity that Duncan has described. It reflects the hard work that all PCNs are doing currently, and through the excellent leadership of the clinical directors that we have in Derbyshire. And like I say, it is so important that general practice has that strategic voice at the big table. And corralling the views and opinions of 112 practices in Derbyshire is no mean feat. But I'd just like to just step back a little and just think about another 3-letter acronym that wasn't on Duncan's list, and that's CCG. And what is a CCG? And the question is it still relevant? If we cast our minds back, the clinical commissioning groups were set up through the Health and Social Care Act of 2012, and that was based on the 2010 white paper. And it was quite simple, really, the premise of this. And it's to create a clinically driven commissioning system. And for those who are long in the tooth, like myself, you can remember that the previous iterations of commissioning organisation, PCTs, PCGs, and so on and so forth. But the whole thrust of a CCG was to be clinically led and clinically driven, and to work with healthcare professionals, patients, local communities, local authorities to commission healthcare services for our patients. And I would stress for our populations and not just patients. And that gives the sort of strategic steer of where CCGs have tried to go in the past. But ultimately, the whole point of this was to give GPs a say. And it's still pertinent today, I think, to remember that CCGs, by their constitution and by statute, are membership organisations still. And hence the need for a governing body. And on that governing body, there is GP representation through the GP representatives. There's also clinical input from secondary care doctors, and fortuitously, I think, in terms of Derby and Derbyshire CCG, we have a strong GP input, I think, through my role as Executive Medical Director, though that may not necessarily be a GP, obviously, and fortuitously through our Chief Exec, Chris Clayton, who's a GP by background. And indeed, my 2 deputies are both local GPs as well, Kath Bagshaw and Sam Taylor. So we do have that ability to influence things, not just through the provider lens, but also constitutionally and statutorily through the CCG. And I think that's really important, touching on the things that Duncan had spoken about in terms of addressing the long-term plan, addressing health inequalities going forward. And I think it's as well to remember that a CCG is clinically led and driven. It may not feel that way because obviously what is a CCG for? As Duncan has said, as a purchaser or buyer or payer, call it what you will, of a huge breadth of healthcare services, and that includes now primary care commissioning through co-commissioning arrangements, but it's increasingly becoming more CCG focused. A plethora of community services, elective care, urgent and emergency care, rehab, mental health, individual funding requests, a whole gamut and spectrum of commissioning activity. But fundamentally, we are a local commissioner of services in collaboration with our local authority partners, Derby City and Derby County. And let's not forget also the 4th purchaser, and that's NHS E&I. There's still quite a number of services that are being commissioned directly from region. That includes an element of IMS and VACs, that includes specialised services, essential services, prison health, and so on and so forth. Let's not forget equation there. And coupled that commissioning activity does come a statutory function, as Duncan has alluded to, and that is ensuring quality of services that we actually contract and commission. So fundamentally, it's a very complex arrangement, but interestingly, it has stood, I think, individual GPs can make through general practice representation at governing body. Obviously, there's conflicts around primary care commission, and that's a separate issue. But the broader strategic themes, general practice through CCGs can make a contribution towards that strategic view. And what is it? And people think that the CCG, what is it basically? And in basic terms, it's split up into directorates. We've got nursing and quality, finance, contracting and commissioning, and my own medical directorate. And the medical directorate is a pretty new concept. And within my part of that empire, if you want to call it that, I've got the primary care commissioning team, primary care nursing and quality, the GPIT infrastructure, and the meds management team, which has got clinical policies and pathways, medicines optimization, the medicines order line, and also we've got all the long-term conditions team, which is increasingly, I think, going to play an important role going forward to address the health inequalities in particular that are apparent within our system. And where does it all fit together? And as Duncan's really eloquently described, how does this all mesh together in terms of an integrated care system? And it is hideously difficult because of interests, let's say, within that. And let's not forget, ICSs are not on a statutory footing at the moment, and that may well change. One of the learnings through COVID, it may well change. And in many ways, it has to change because the inbuilt imbalances within that ICS are what's hampered the function of an ICS in the past. So where do I see this going for the future? So CCGs, as you know, previously there were 4 in Derbyshire, and due to various pressures within the system, there was a merger, obviously, that people are very much aware of, into one CCG. And in many ways, I think we were very much ahead of the game in doing that. And it's forestalled an awful lot of problems, let's say, and tensions that are built up in other integrated care systems, and some of them quite close to us. So in many ways, we're on the front foot with this. And how does it stitch together in terms of an integrated care system? What is the role of the CCG? And increasingly, that role is becoming a strategic role, coupled with our local authority partners, about looking at those very things that are outlined in the long-term plan, about addressing health inequalities, about the whole plethora of services that we can offer much more equitably across Derbyshire going forward. And I think going forward, I think there will be an element of regional collaboration between CCGs, and we're already working in a pilot form with colleagues in Nottinghamshire and colleagues in Lincolnshire to scope out what elements of specialised services that are currently offered through regional commissioning, what we can do collectively to really own the problem in many ways, because one of the weaknesses of regional commissioning is the lack of intelligence of where the deprived communities are within our footprint, where the health inequalities exist, and in particular, what can we include in that envelope of primary care commissioning? And I'm thinking more broadly in terms of pharmacy. I'm thinking more broadly in terms of dental, optometry, and so on and so forth. What can we bring together commissioning wise on a more localized footing, and to really strengthen the position of the ICS? And again, the ICS, in many ways, the COVID situation is impacting on all of us, as we're very much aware, both operationally and tactically. And certainly, one of the learnings from COVID is the necessity for that coordinating function to be strengthened in the integrated care system. And personally, I do see that as a key role and key strength of the Commissioner going forward. Yes, as this crisis unfolded, there was national directives. There was a directive approach with block contracts. There's a directive approach in terms of what we should drop literally and what we should focus on. And there's a sidetracking, if you will, of governance, which is perfectly understandable and perfectly a necessity given the urgency of the crisis. But going forward, we do need an element of reconstruction of that, but in a user-friendly way, because what we do not want in the ICS space is another layer of bureaucracy. And what we do want, as I've alluded to, is the powerful voice of general practice, both as a provider, as a unified voice as a provider, but also more subtly, I think, through the Commissioner, because unless statute changes, we are still a membership organisation. And I think that's an important point to remember for colleagues on the call, that we are still a membership organisation. And I'm not going to go into the detail of the long-term plan, because I'm aware we're beyond 9 o'clock now. But I think you've had a broad view this evening about what our system is beginning to look like through the lens of individual practices, through the emerging primary care networks, and through the wider GP representation, through the GP Alliance and the good work that Duncan and his colleagues have been putting in, and then more widely into the Commissioner space, where, like I say, GPs still have a role to play, and where that widens out further into the integrated care system for Derbyshire as a whole, and perhaps more collaboratively across the region going forward across CCGs. So I'll just stop at that point, obviously, because it is getting late now, and happy to take questions, Tara.
Thank you very much, Steve. So over to questions. I've got one in the chat, which is about sort of relatively. I've got two now. So I will hand over. I'll ask Sarah Todd if you want to ask your question first, which I think is probably slightly more to Duncan than to Steve. But Sarah, if you want to unmute yourself and ask.
Hi. I just wanted to know a little bit more about the Derbyshire GP Alliance, because I wasn't really sure what it was, and if that's got issues with its funding or who it's funded by. Thank you.
You can answer that, Duncan, or shall I?
Yeah, I'd probably easiest for me to answer it. So a couple of years ago, just after the CCGs came together, there was a bit of a crisis meeting, and I think Steve was there and Chris Clayton. And the crisis meeting was called because general practice really didn't feel as though it was being heard. And in the year prior to that, PJ Flann, who's currently a clinical director in Chesterfield, myself and Kath Marcus, we're trying to get a seat at Joined Up Care Derbyshire at the STP board, so that we could at least have some providers of general practice with a voice being heard. And so through, I think it was 2018, we formed as a group of interested GPs, so GPs that had a leadership role that was above their own practice. And then through that year, we formed into a group of about 35 GP leaders from across Derbyshire, and our membership through that year was very broad, in that anybody that had a role in GP leadership that was greater than that of their own practice were eligible to be part of it. And as a group, we then wrote the Derbyshire vision for general practice. So we wrote this vision, which talks about how we can look to transform services, which has been then adopted by the CCG and endorsed, as well as Joined Up Care Derbyshire. The reason I was a tiny bit hesitant about talking about the GP Alliance is because I think we're moving into the next phase of that. And this is, I'm not sure where Sid's up to with explaining and talking through things, but the idea of a general practice provider board, so a coalition of what was the General Practice Alliance, so a primary care clinical director-led GP leadership group working in conjunction with a sort of transformed LMC to provide an effective and mandated then leadership voice across general practice. So the way in which that GP Alliance had been funded, so the first 9 months it wasn't funded. So the 35 GPs that wrote the vision and did all the work on it, did it in their own time. And we were meeting up in our own time just because we thought that it was a really important thing to do for Derbyshire. We needed to make some progress with it. And then into 2019, we negotiated some funding with the CCG. So the CCG fund the GP Task Force, which is an offshoot of the LMC, to provide GP leadership into sort of senior system meetings. So it's indirectly funded by the CCG. I think the way Steve will almost certainly have a slightly different approach to this, but this is because we look at the world from completely different sides, which is fantastic. But I see this as very much a system responsibility. It's critical, if the system's to be effective, that there is a voice for general practice there, and that voice needs some degree of funding. And so the CCG have agreed to fund that, and I think I see that as a system funding us, although it is absolutely coming through the CCG.
Thank you very much for explaining that. And I've got a question about sort of a specific thing, which is about a priority area, which seems to be a national hot topic, which is about children's mental health services. A question really thinking about what does the CCG envisage as a plan for children's mental health services for the future? Because I think we are all in a situation where we are feeling it is not good enough, and I know that's a national and local issue. Are the CCG considering this to be a priority, and what are they doing about it?
Absolutely. Just stepping back, the whole issue of mental health funding and commissioning, both children's and adults, I mean, that sits with the Contracting and Commissioning Directorate. But fundamentally, that is a priority area going forward. Always has been, always will be. And the simple answer to that is yes, it is a priority. Like I say, I'm not close to it personally. Saurabh may have a view on this as our clinical lead in terms of mental health, but it is a priority area, including the mental health investment standard, ensuring that we're compliant with that. And that's all I can say at this point.
Okay, thank you very much. Any other questions? I hope I haven't missed any questions off the chat that have been put through.
I mean, I could just comment on that if you want.
Absolutely, sorry, but if you are willing to comment on that, that would be hugely positive.
I'm not actually an expert on the children's side, to be fair, because it's often shared responsibility with children's commissioners. But I think what I would say is that there are some big transformational things ahead, and they will include children. The government have put money into children's, and therefore we've had a lot of investment in sort of support services for CAMS, which is, you know, adolescent and children's services, but around schools. And there's a lot of things going on which are sort of outside of your immediate view, but they are supporting the children in various ways and the parents. I think there's a lot more to be done, and I think primary care will be expected to be supported and involved in that in the coming year. So let's keep an eye on that. But yeah, I think broadly speaking, definitely this is a priority for the CCG, but also for the whole system. Yeah. So we'll do more, we'll keep doing more.
I think the thing to remember is that within the ICS framework, we do have work streams and programs around mental health, or long-term conditions, maternity, children's, and that is one of the strengths of the ICS approach. This collaborative approach between providers and commissioners to deliver programs of work and around key theme areas. And I think that needs to be recognised and remembered when we move to this ICS way of working. It is a collaborative approach to problems. It's not just a commissioner problem, it's all our problems. And for example, the Mental Health Board that SORAB contributes to so well is a good working example of that. And indeed, the element of children's mental health within the children's work stream is well recognised.
Yeah, I would agree with that. Yeah, it's not a. We need to try and forget this. I mean, I know the CCG is key, and GPs have been key within CCGs because of Lansley's reforms, and I think this is a good thing overall. Clearly, we've moved on since then, and I think at some point the future is not about just payers and doers. It's going to be much more collaborative, because, and the reason it has to be like that is because the NHS doesn't lend itself to health, doesn't lend itself to the marketplace. It's not the same. It's better if we have a collaborative view where actually at the end of the day we're looking after the whole population. Everybody's in it together, as Steve's certainly indicating there, and that does solve problems that are insolvable. And very quickly, I mean, the ECG problem for people with mental health, I mean, that's been going on for decades. Trying to solve that by just using the usual method of commissioners, are we commissioning the mental health services? Are we commissioning the GPs to do it? Where do the patients go? They usually end up missing out. All these sort of difficult problems that keep coming back year after year will be much better solved with an ICS than with the traditional model. So, yeah, does that make sense?
Yeah, I think so. Thank you very much. So unless we've got any other questions, thank you, a huge thank you to Sid and Duncan and Steve for giving up their time this evening, and thank you everybody for coming along. Much appreciated. If you've got any feedback that you want to give to speakers or about evening meetings, if you want to stick those in the chat, feel free to do so, and then I will make sure that the recording from tonight is available on our South Hardwick PCN private YouTube channel later on today. It's a private YouTube channel, which means if you've got the link you can get to it and find it, but you can't search for it, so it's not sort of completely public. But if you know a colleague that says, oh, I really wish I'd been able to be there, you will be able to share that link with them and get them to it.